coming to this late session because it is extremely important. This session will examine the impacts of illegal drug use statewide. The use of illegal drugs such as heroin and methamphetamines, as well as the ongoing abuse of prescription medications, continue to affect localities' ability to provide and maintain a healthy workforce. This session will highlight the actions the state is taking and how localities dealing with these issues can be involved in state education. I would like to introduce Secretary Bill Hazel. Dr. Hazel has practiced orthopedic surgery in Northern Virginia until becoming Secretary of Health and Human Resources for the Commonwealth of Virginia in January of 2010. He is a founding member of Commonwealth Orthopedics and Rehabilitation. His professional experience includes working as a team physician for the Chantilly High School Chargers, serving as an assistant orthopedist for the Washington Redskins football team, and serving as team physician for the DC United soccer team. During his first term as secretary, he led the Virginia Health Reform Initiative and helped establish the Virginia Center for Health Innovation. He has become nationally recognized for leading an enterprise information technology transformation in health and human services. He has devoted significant energy towards improving the effectiveness and efficiency of HHR agencies. Welcome, Doug.
Thank you. Thank you. Will you introduce us both, or you want me to go?
I'll wait and introduce her.
Okay, very good. Thank you. Well, date notwithstanding on the slides, it is November 9th, is that right? And I want to talk more probably about opiates than we will about other drugs right now, such as marijuana, meth, and so forth. If you were in the room here for the session before, right at the end of it, the gentleman from Giles was asked specifically about the drugs. He says, we see a little bit of meth, but the real problem is opiates. And I'll start by, has anyone here read the book Dreamland? Okay, I'm going to make a reading recommendation to you. Dreamland is written by a guy named Sam Quinones, Quinones. And Sam is an investigative reporter for the Los Angeles Times who worked with gangs. And this book tracks two things that happened simultaneously beginning in the late 80s through the present day. And one hand is what happened in medicine. And as an orthopedic surgeon, why this book resonated with me is it described what happened to me in practice and what I was seeing in practice. And so in the late 80s, internationally, there became this movement to recognize pain as the fifth vital sign, as temperature, pulse, blood pressure, heart rate, respiration. I'll get it right eventually if I think about it. But all these things that we normally think about before vital signs, in healthcare, decided that there would be a fifth vital sign. So the Joint Commission on Healthcare began educating all of us on our ability to put the smiley faces in front of you when you're in the hospital and tell us how much pain you're having and ensure that your pain was adequately treated. Does anybody know how that movement was funded? Pharma. Yeah, pharma funded that. And some of the studies were pharma funded. And I can't say that offhand it's bad will to try to resolve these problems, but there certainly was that there. And then as we move towards consumerism and you're a doctor or a hospital, what happens? The first thing that you get when you get home, or you get a telephone call regarding how did they treat you? And how was your pain managed? And so we in the business were taken to task not only on the crediting, but also on the Press-Ganey scores and so forth. We had to manage pain better, and that became a thing unto itself. I can remember in the early 1990s, drug reps in my office talking about OxyContin, saying that, doctor, they will not get addicted to OxyContin and Percocet if it's given after surgery, because that's not a pleasurable experience. It happened. And then I started soon thereafter, as soon as it came out, it actually worked very well with post-op patients. It's a shame that what's happened has happened. But I can recall the inevitable 505 phone call from the answering service on Friday with your partner didn't refill my Percocet prescription and I needed phoned into Stafford. Every Friday, something like that would happen as we've gone through this. So what happened is we begin to get more and more pills on the street. And these pills are misused. They're in the medicine cabinet and the grandkids get it. Or one of the things that we know is somebody who's in hospice dies and they only get half their prescription and the family goes and picks up the other half. And there becomes a market in pills. And I believe that OxyContin today on the street is worth about $1 a milligram. 60 milligram tablet's worth about $60. Now we got smart. We said we're going to fix it. So we developed a prescription monitoring program and we try to cut down on this and we make this stuff harder to get. And then what happens? Well, that's the other side of the story. So, we think of heroin as something that happens in inner cities and a guy on the corner hustling heroin and it comes in the ports and it gets cut down 3 or 4 times and you're selling it. But what Quinones in this book describes is how the market's changed in this heroin distribution. And in fact, getting heroin today is probably not any harder than ordering pizza. They'll deliver to you if you want it, and it costs, a day's fix costs about the price of a 6-pack. So unfortunately, in opiates, we have this, it's probably the only place in pharmaceuticals that markets work. You can laugh at that. It is cynically funny, but if you can't get one, you get the other. And this marketing of the heroin has been very sophisticated. They'll go to methadone clinics, watch the people coming outside, they'll give them samples. Very pure heroin that we couldn't get before. Now, I don't know that the group that he describes in the book has come to Virginia, but I know it's in Ohio and Kentucky and North Carolina and Tennessee. And I wouldn't be surprised if we see some in Virginia, but the marketing of this has changed. So all along, we've been thinking of drugs and opiates as a problem that certain populations have, but a couple things have happened. And in Virginia, you see this. The number of fatal heroin overdoses by years has skyrocketed. Probably we were late catching it because the way the medical examiner's code is poisoning, and we probably weren't early on getting enough of these caught, and it crept up on us. Another thing that happened is that the tendency to think this in Northern Virginia is a Washington, D.C. problem. It's heroin. Failed to recognize that this was crossing over into suburban populations. Kids can get these pills any place. They get them at parties. They share. My profession, sports medicine for kids, has pushed use of opioids. And when you get an addiction, let me step back for a moment about what we're seeing in the epidemic. But addiction changes the brain. And we have new technology now called fMRIs that can look at brains of people, normal people, if you can find any normal people. I'm skeptical about that, actually. But if you compare a brain of someone who's not addicted and a brain of someone who is addicted, it behaves differently during different cycles of function. And it shows on tests. And this brain rewires itself during the pattern of addiction, and when you take it away, the brain doesn't unwire. It doesn't rewire automatically. It takes time to get through the process of healing. And it is well beyond the normal month or 6 weeks that we generally would think for detox and treatment for alcohol and so forth. It just doesn't work that way. So what we've got now is we are seeing the tip of the iceberg here. What do I do? Tip of the iceberg here with the deaths. Now, the question then is, where is it in the state? And it's in different areas. And what we have learned, this is the number of deaths, and this is the rate of deaths. And interestingly, you see this problem popping around Northern Virginia. What's happening up here around Winchester? What's happening down here? And then looking at this down in Southwest Virginia, what we think is it's not exactly the same problem everywhere. The distribution routes for the heroin, for instance, are coming in. These are coming down from Baltimore possibly, Philadelphia, potentially here. There are others who are experts. I've heard these are coming up from Atlanta, seacoast, and then this area is getting it from the traffic that's coming out through Appalachia, which has been devastated with opioid use as the economy has slacked off. And one other thing I will tell you that contributed in many areas is the pill mills. For many years that we had problems with opiate prescriptions coming out of Florida, but there became a movement of pain management, and that became less about all the holistic evaluation of pain, but more about the pills. People would show up using assumed names, different names, bad record keeping, and as Ohio shut down their pill mills, what happened? They moved to Kentucky. West Virginia's secretary called me a couple months ago and says, we're closing 2 down, watch Whitfield, because that's where they're coming. They are already in Whitfield. And so we have this problem of unscrupulous practice as well that we're trying to address. And I would point out that some of these opioid could mean heroin or it could mean a prescription medication. My understanding is that these in this area are more heroin, the deaths down here are more prescriptions. So it is a different problem in different parts of the state. Now, we appointed, or Governor appointed a task force to look at this back early in the year. Secretary Moran and I co-chaired. Actually, this was a year ago we started it. There were 5 work groups, and education was one. That was both public and provider education. Treatment, something I want to talk to you a little bit about. Storage and disposal is a problem for your local law enforcement folks. The sheriffs ultimately get this stuff, and then what do you do with it? It's not easy to dispose of. And then we have a whole series of concerns about how we monitor the data and look where the trends are, and then the law enforcement issues. So the recommendations of these work groups, I mean, there were multiple meetings over a long period of time, and it went well enough that oddly enough they asked me to come to North Carolina last week and talk to their task force on this because they think we figured something out. And I think that may be a case right now. The grass appears greener on the other side of the border, but it's not just us. So the first thing was access to naloxone. Naloxone is the medication that, when administered, reverses the effects of the opiates. It blocks the sites that opiates bind and reverses the effect. This saves lives. We use it in medicine frequently. We use it after anesthesia, but we have made that more available in Virginia in the past year. We've tried to train law enforcement to use it and other first responders, and the goal here is to make it more available for harm reduction. If someone is going out with prescriptions, or we know there's a known heroin user, we know that eventually they will relapse. And if they don't have their normal source, they may get it from a source they don't know, at a strength they don't know, or cut with something different like fentanyl or whatever, and it becomes more dangerous. So if you're just looking about death prevention, the naloxone is actually something that's really necessary. Another area that we have focused on is maximizing our prescription monitoring program. Does everyone know what that is? Being good leaders, you're sitting there and not acknowledging you don't know what it is. Yeah. In the Department of Health Professions, we've set up a program that monitors where people buy their narcotics, and the pharmacies have to report to that, and we are hoping, and I hope that we make use of it mandatory when you're prescribing opiates. What should be able to happen is, and what does happen where we have the data, is we've seen evidence of people doctor shopping or pharmacy shopping up to 15 pharmacies. We are beginning to have better data. Maryland, fortunately, just 2 months ago came online, so if you're in that area, you can actually find out where people are shopping for pills in Maryland. And this is a way that we have begun to cut down on the abuse of prescription monitoring. It is very, very effective when we get the data and we have it. And some of the things that we're looking for are how we create reports, how we would tell law enforcement we've got a problem here. Those are things that historically we haven't been allowed to use it for that purpose. But we actually want to take the docs and go back and say, you're really an outlier here. Why? And some of it can be legitimate prescribing. For instance, pill mills are the #1 source. What's the next source? Well, I shouldn't say that. Primary care is the main source of it, but when you look at, you've got the pill mills, but the other places that prescribe narcotics could be cancer treatment centers. And one of the challenges you have is you have very legitimate needs to control pain, but if 20% of their population is using medications inappropriately, consistent with the rest of the population, are they taking their medicine or are they selling it so they can get something else? And these are things that we're seeing and having to work with the profession on. And folks, I can tell you, Koren at UVA are doing a really good job around this right now, trying to sort out who's, are you getting, you're getting a urine test, we know whether you're taking your medication or not. The treatment becomes important. I'm going to come back to that, and then I want to talk a little bit about the drug courts. So we have a number of recommendations that we have already implemented to try to reduce this. This is largely around prescription drugs and limiting the availability. We had a gentleman who runs the high-intensity drug trafficking agency from Appalachian stand up at a meeting we had down in Wise. I'll tell you a little bit more about that. And he said there are just too many pills out there. And the problem we have in law enforcement is we chase bad guys. We don't chase doctors and nurses. We don't like to do that. We don't know how to do that. We need another system for that piece, but we can't keep up with all these damn pills. And so it becomes really important for us to work on that. So the storage and disposal, I think, is listed here. The challenge is you can't just burn this stuff. You can't dump it in the water and so forth. And we do have an incinerator. The incinerator in Virginia is in Alexandria. But if you're down in Giles, it's a long way to deliver stuff to. So we're trying to figure out how to take back drugs. And when they do these take-back events, they get pounds and pounds of medications that are coming back. So it becomes a real problem for us. We are looking at developing a state website. That will be done through health professions, the drug take-back, so forth. We are developing an opioid curriculum for law enforcement. CIT training light or CIT light training has a big role in this. We need to think about treatment. And historically what we have done is we've said, okay, you're an addict, you know, it's a moral failing and you need to toughen up and get over it. And even a lot of the peer community, which is heavily engaged in treatment, and you don't want to do anything in this area without peers, typically the thought was, I can do it, you can do it. But what did I just tell you about the brain? Yeah, it doesn't work that way for a lot of people. And I think what you're seeing more and more, and we've heard now from peers, is they're beginning to recognize that there's a place for medical assisted treatment. But then Stewart says, but that's just giving them one pill to substitute for another pill. The difference is the new pill you can function on for one. And I think that when we talk about medically assisted treatment, the key word is assisted. Just giving another pill to replace the one without the psychosocial therapy and things like that doesn't really work. It is just kicking the ball down the field a little bit, and it doesn't help. So we need to get that, make that more available. And currently we're exploring a substance use disorder treatment waiver with CMS, trying to figure out where we can get the funds to begin to do more of this in the Medicaid population. Now the unfortunate thing is most of the people who are in jails or out there with these problems are not eligible for Medicaid in Virginia, so even if we get that, it won't help so much. That's just my editorial for expansion. There are law enforcement issues here around creating alternatives to incarceration. You can pay for them to be in jail, they can detox them, and guess what, when they leave, behaviors haven't been corrected and they'll be back, and that's what history shows with this. We have seen, and just to kind of get this down, I've been very impressed with the option of drug courts. There is one in Caswell that I visited twice. Judge Hurley down there, anybody know Chip? Judge Hurley down there has had 13 babies born drug-free in his program. 13 babies born drug-free in his program. It's amazing what they're doing. It is, it is, for him, I think, a labor of conviction. But it is something when you have the carrot of a better outcome and the stick of, well, you know, you can always go back to jail, what choice would you like to make? Invariably, you get a choice that pushes you towards the right thing. And we've had some difficulties in Virginia. It's not without cost to do these. I think we only have 24, 25 drug courts in Virginia. West Virginia will have a drug court in every jurisdiction by the end of this year, I think, because they believe in it, and they've had a worse time with this than we have. So it's really important that we think about how we do it. It does require some funding. You do have to have treatment availability. And there have been some areas where they say, yeah, we'll have a drug court, but we won't do this medically assisted treatment stuff. And it's hard because you don't know, you can't test to see whether you're using the medicine appropriately. It is difficult. But I'll tell you, the feds will make have made all drug court funding contingent on having medically assisted treatment available now. So that becomes less of an option. We've already talked about this, getting disposable out there, and what really took me by surprise as we worked through our task force is the police chief one day from Virginia Beach got up and just in the back of the room, he said, we can't arrest our way out of this problem. We just can't. And there was a couple sheriffs and other police ones. Is he speaking for all of you? And they all nodded, yeah. I mean, these guys, they haven't given up, but they can't keep chasing this ineffectively, and that's what we've been asking them to do. So the challenge then becomes, all right, what are your other options? This talks about the drug course. There is cost available. Average cost on tax referral to exit was about $7,000 to $18,000, but it's $19,000 to keep them in jail during that period of time, and they'll be back. So I think that's the thing that I would like, and the evidence does show a lower recidivism rate, and generally the thinking is now that this works. Where are the drug courts? There's the adult, the juvenile. I know that Winchester is leading a community effort right now to build one, and that they think will be very effective. Now I had called the state police, chief of state police, Colonel Flaherty, back in August. The colonel, I said, one thing we've had this task force, and law enforcement's been sitting there, but we don't hear much from you in this task force. And said, who can come over and brief me? And sent the major over, and we had this long conversation, and he was telling me all the challenges they have in law enforcement. I said, so where are we getting it right? He said, you're getting it right in Winchester. Winchester? Yes.
I'm next door.
Yeah, okay. And
Part of the group.
Well, Winchester got a little bit of, got some impetus from Valley Health up there, the prosecutors, social service, the Casey Family Programs is a national program. Jim Casey was the UPS founder, and he's funded 5 different charities, but it's all around families. Why would Casey Family Programs, that's interested in foster care, come into Winchester and fund a program on opiates? Because substance abuse is the leading cause of foster care in the country. And who's taking care of those kids? We are. Yeah. This call and response part, who's taking care of these kids?
We are.
Yeah, we are, big time. So they have been working together, remarkable efforts in their ICU for the neonatals with the neonatal abstinence syndrome, diversion. They're developing a drug court, and it would appear they have lowered their death rate significantly in a very short time. But I think the key to this, and what we learned at our WISE Summit, is there's a culture change that has to happen in the communities to fight substance abuse. It's not going to be a policy and procedure thing strictly. It's got to be a culture change that will come by bringing peers, parents. Another thing that has there have been some parents up there in that area that have lost kids, and they've come in and they've told their stories, because it's not happening to them anymore, folks. It's happening to us. It is happening to folks that we know. And I think that's really one of the biggest changes that we're finding. This is how they got theirs together, 100 critical leaders, 3 communities. They looked at the data, launched launched their website and have had good success with it. And if you want to do this, the thing that I would say probably that I've learned is you need to have the local groups come together around this. We did a summit in Appalachian down in Wise back in September. You know, I told you earlier that the face of this problem is different in different areas of the state. And down in the Southwest, I mean, you can stand in Wise and you can get to West Virginia, Kentucky, Tennessee, and even North Carolina quicker than you can get to Richmond. And so we invited North Carolina, Tennessee, Kentucky, West Virginia, and Maryland in, and we had 100 and some people in for a conference. And again, these are sort of the takeaways. You need to support the incarcerated-based treatment in drug courts. We have to look at the utilization of the local resources. Kentucky has something called Operation Unite, which was funded by ARC, Appalachian Regional Commission money, which has done an awful lot towards getting the word out, engaging the community, and that's where the prevention occurs. You look at the peer engagement in those processes is important. Recognizing that we've got to add the medically assisted treatment, then looking at the recovery community, and then there's this issue of harm reduction. If you read the papers, there's an outbreak of HIV in Indiana associated with needle sharing. And we can say, well, if we're giving them clean needles, aren't we just supporting the drug use? And we may be, in a way, but they're going to use the drugs anyway, and now we've got HIV to contend with. I know that there was a breakout of hepatitis down in Southwest Virginia last summer, a year ago, from shared needles in a community. So these are things that will be popping up, coming to a location near you soon, if they haven't already. We need to think about that. So, I try to sum this up into really, I will say we've also at the administration really set up the Center for Mental Health and Justice. But what I will tell you is my simple way of thinking is there are 3 issues here. We now have a large population of people who are addicted to this stuff, and they will be addicted. And they're our friends and neighbors and families, and the treatment has got to be there. We need to prevent future addiction. Peers play a lot of role in both of those, and then the third is we've got to continue the interdiction. We still need the law enforcement. These are our partners in this, and the law enforcement people I talk to say, Doc, when we have these meetings, please include us, because we're the first step in the intervention. So with that, I'll turn it over to Senator Phil. Back to you to introduce the senator.
Thank you. Thank you. And we will have questions at the end of the session. I introduce with pleasure Senator Barbara Favola, who has been a resident of Arlington since 1982, and she represents the 31st District. From 1997 to 2012, Senator Favola was a member of the Arlington County Board of Supervisors. She served as chairman in 2000 and 2004, and vice chairman in 1999, 2003, and 2011. Senator Favola serves on Virginia's Senate Local Government Committee, Rehabilitation and Social Services Committee, and Transportation Committee, and is now the chair of the Women's Reproductive Health Caucus. Welcome.
Thank you. Thank you. It's really a pleasure to be here. I was very active in VACo during my years on the Arlington County Board, and I was your president-elect until that was in 2011, and then I won my election to the Senate, so I couldn't serve as your president, but I almost gave up my Senate seat.
Everybody makes mistakes, Barbara.
That's true. I guess we have to move on, right? That's the message here, move on. I do represent portions of Northern Virginia, parts of Arlington, parts of Fairfax, and parts of Loudoun. I drew heavily on what my largest jurisdiction, Fairfax, is doing to combat this problem. So you'll see, I know, Katie, you're the legislative liaison from Fairfax, so some of my facts will sound familiar to you, but I thought you might find it interesting as well. In Fairfax County, the number of deaths from heroin overdose doubled between 2013 and 2014, which is an amazing statistic. The Board of Supervisors took it very seriously and charged the police department with setting up a task force, and they wanted it to be, of course, inclusive, and they wanted all the players at the table. And the Fairfax Police Department did that. They convened the task force, and they included not just themselves, the police, the sheriff, fire, rescue, fraternity, health professionals, parents, community activists, the neighborhood and community services groups, and also healthcare professionals both in the schools and outside the schools. So this task force came up with a plan that had three major components. One was education, one was treatment, and one was enforcement. And I will just highlight the areas that the doctor may have just went over quickly. But this is what Fairfax decided. In the area of education, they were trying to increase the safe disposal of unused prescription drugs because they felt that when prescription drugs were not disposed of properly, young people could actually access those drugs and you would have a problem. There are these sort of national take-back, semi-annual events where jurisdictions can turn in, and of course individuals and healthcare providers can turn in these unused prescription drugs, and I believe the state is a partner in these national take-back events. So
They've just reinstituted them. The DA had stopped them for a while, but they've just restarted them. And yes, we do help them with that.
So that is something as the local level you can participate in. The local government, Fairfax, was calling for promoting the best practices in prescribing opiates. Now this would be something that your medical community, of course, would have to issue these guidelines, but they felt that best practices were not being used, and this was feedback they were receiving from their own healthcare professionals. So I thought that was an interesting point, and that may be something that the medical groups and your department can take a lead on.
So CDC has put out guidelines for pain management that have just come out, Centers for Disease Control. As a result of this, there are some other guidelines around just normal prescribing that are being developed. What we have done, and I think will be a bill this year. Senator, I don't know who's going to carry this one yet. But I mean, I come out of the medical society. I'm a physician, and we have always resisted tooth and nail any mandatory continuing medical education. It's always say they need to teach better in schools, except that I've been out of school for a long time. So there will be a bill this year requiring physicians who prescribe certain amounts of narcotic based on PMP to have continuing medical education, and I think the profession will support it. Perhaps not unanimously, but yes, that's in the works.
Thank you. My comments are sort of turning into,
I'm sorry.
this is what we need. No, this is exactly what we need. I'm so happy you're responding. Then the other issue that came out in the education component of this plan was to really monitor the prescription use of opiates. So this required better parent education. This required public education, actually. And Fairfax decided that they really had to talk to their coaches, their athletic teams, their physical therapists, and others who worked fairly regularly with young people. Because there's some signs, and you would know better than I, Secretary Hazel, on if a person might be addicted to an opiate. There's a way that you can detect that. I don't know what those symptoms are, but the point is that you would want to put that element into your action plan. Another area, of course, that Fairfax incorporated in its action plan was in the area of treatment, and they heard loud and clearly from their first responders that they need to be ready to treat the individuals. They need to have access to naloxone, N-A-L-O-X-O-N-E, naloxone. So an issue was made to sort of respond to that, make sure that the professionals had access to that drug and knew how to use it. And then, of course, Fairfax widely advertised, if a person is suffering from an emergency situation, you call 911. If it's not an immediate situation, but a person actually does need some kind of treatment, you call the Community Services Board, and there is a phone number available 24/7. And then I just want you to note, the General Assembly recently passed a bill which would provide what we would call a safe harbor. So for an individual who may be using himself or herself, but knows that a friend is really in dire need, that person can call and not risk being arrested. So, which actually was a big deal. Lawmakers were being told pretty regularly that, hey, not that somebody would admit it right out, but I know of a situation where I know of people who have observed individuals who were really overdosing and didn't want to pick up the phone because they were concerned about an arrest issue. The bottom line here is, and it will be a financial issue for you, and I want the state to be a strong partner, you are going to have to create enough treatment slots. Because if, in fact, you do what we hope you will do, one issue we want you to take away from this session is prioritize treatment over the punitive measure of putting an individual into jail. I mean, that's the purpose of a drug court. That's what you would call your diversion programs. And you have to have the treatment slots available. And from a policy perspective, I think your message to the General Assembly should be, the state saves approximately $20,000 per year per individual who is not placed in jail, but is put into an alternative program in the community. Those dollars that the state is saving should be made available to flow through your Community Services Board so you can create these slots. I don't know if there's anything else I want to cover that has not already been covered. One other issue you might think about, but this also was articulated in the Fairfax plan. There's a lot of interest in increasing the prosecution of the distributors, those who actually distribute heroin and opiate drugs. Virginia, along with several other states, did pass a law that I think really strengthened the tools for issuing stiffer sentences to these distributors. There's very mixed opinion on whether or not that approach is working. I'm not going to say it's bad, I'm not going to say it's good. Certainly these distributors should actually be prosecuted, and they should be prosecuted to every element of the law. I just don't have any evidence on what a best practice might be when you're in the midst of prosecuting. That's about it. The other information I have, Secretary Sullivan. That's why I used to work with at Health and Human Services. Secretary Hazel very thoroughly covered the other issues.
People confuse us all the time.
All the time. They're both doctors, that's about where it is.
African-American gentleman from Atlanta. We get confused all the time.
Other than I work for Secretary Sullivan. Maybe inadvertently I want to work for you. So we're happy to take questions. I don't know if you have something that's really compelling you want to ask us, but even if it's not compelling, any question is worthy of an audience.
Have you seen any uptick or any way to correlate an increase in crime related to, this whole issue of getting the money to purchase these drugs and heroin and that kind of thing?
We don't, I don't have in Health and Human Resources the crime statistics, but the public safety does have some. And what I can tell you, it goes way beyond anecdotal. When you go to the drug courts and you listen to the stories, generally the arrest is for something related to a drug-seeking activity that involves a crime. And I can say confidently it does happen. Somebody's got the numbers. I don't have them in my head. What I can tell you though, when she talked about the punishments for dealers, there are different types of dealers. There are the really bad guys that are getting stuff out en masse, but what's happening, say in Northern Virginia, is somebody runs up to Baltimore gets the heroin, sells some to their buddy to cover their own costs, and the two of them use. Is that a dealer or is that an addict that's supporting their habit? And I think that for law enforcement, that becomes a real difficult distinction sometimes. The Good Samaritan law is intended to allow someone at the scene to call and report an overdose so that an individual can get treatment. It does not automatically confer immunity from prosecution. That can be overinterpreted, but there is a degree of protection. I don't know the law well enough. I am not a lawyer. Don't play one on TV, and didn't sleep at a Holiday Inn Express last night. So I can't tell you the legal theory. But it's not as clean as one would think.
But to your question about whether there's additional criminal activity related to the distribution of these illegal drugs, there is. And so to the degree that, we can provide other supports to our young people, it would be very helpful. I mean, making sure you have really strong after-school programs, making sure, kids who might be at risk of participating in these activities are identified, and interventions are made available early. Your gang prevention activities would be extraordinarily useful in combating this situation. So, just food for thought. There were some other hands up. I don't want to take all the time.
Yes.
Yes, I'm Sharon Alsop from
Sharon.
King and Queen. I'm in a rural area, and so we have.
You mention that, like almost every
Every
time
time
you
you-
open your mouth.
But it is, it's a nice, it is a rural area, but we have two distinct problems here. We have our older population who are overtaking medical drugs. I mean, and so they're having the problems. But then we have these younger kids who are indeed taking heroin, but they're mixing it with stuff. And so as we send our EMS out there to try and take care of them, what we've been seeing is that the Narcan, or whatever you call it, I call it Narcan, but they get that, it doesn't work like that like it used to do. And I don't know what that is, because we don't know what they're mixing this stuff with. And so I think it's putting our EMTs at a disadvantage and in harm's way, because they're mixing this stuff and we don't know, perhaps that's not the right thing that we're giving them, is what I'm starting to think.
From what I understand, the deaths are often due to someone who hasn't used and now comes back and uses, where it's stronger than what they're used to. They're no longer adapted to it. Or it has been cut with something, whether it's fentanyl or something else. That's another option. But there's also combinations of drugs being used, sedatives, or
Just like making them. I mean, you find meth labs all over the place. I mean,
Yeah.
it's just,
So that is a very real problem in these combination situations.
Yeah.
But I don't know how we would know when we don't know.
Yeah.
Haven't figured that one out yet.
Yeah, I'm just saying, it sort of puts I'm an EMT, so it puts me at a disadvantage, because I go in there and I think I know what I'm dealing with, and I'm dealing with something totally different.
Yeah.
And so it's worrisome, and most of us have some form of paid staff. We may not be all paid staff, but we have paid and volunteer like King and Queen does. Well, it gets kind of
The good news
scary
is
for.
the risk of Narcan injection, when that's not the problem, is minimal. So
Right.
you're not going to get into trouble by administering.
Oh, no.
It's just that you won't get the response you
That we're looking for, and that's
This is kind of a dangerous question, but can we do anything to encourage the feds to stop the incoming traffic of drugs from Mexico and China, not China, but South America, or is there anything we can do, because it comes into the country and then they find a way for us to use it.
I tell you, I would encourage you to read the book, and you'll see how ingenious these people are about how the patterns change and how they do get the drugs in. The war on drugs has been going on for a long time, and I don't know that there's been a lack of intensity of effort. Barbara probably knows more about that stuff than I do, but every place you see it, and you know, that's why I think what the police are saying, we can't arrest our way out of it. Taking the one side, law enforcement, doesn't address the demand piece of the equation. And you know, these aren't now the Vietnam vets that are coming back addicted in the inner city. It's just out there, and we are doing it medically. I mean, we really are, and to no small part, this is a iatrogenic problem.
So we just have to learn to deal what we have been given and try to deal with it in a new way. You said a change of culture.
Yeah, I
I mean, we can't keep treating it the
Yeah.
same old way.
Well,
We have to-
I was just gonna say, I mean, I think a comprehensive approach is really the way to do it, which would be, as you suggested, trying to attack the flow of drugs coming into the country. I'm not so sure that these drugs are all coming from outside the country. I should say, we haven't established that fact. But we need to get to sort of the root causes of, you know, why people are using these drugs, what are they escaping from, and then we need to treat them, we need to intervene, and we do have to change the culture. I mean, there's something, in my view, there's something wrong here if we have large numbers of our, they happen to be young people, between the ages of 16 and 30, who are really turning to drugs for, you know, either recreation or to escape. So we have to do a much, much better job of educating folks and reaching out to them, finding alternatives.
Finding
figuring
jobs.
Yeah, finding jobs, figure out, you know, what is it that has left their life so unfulfilled, they're willing to take these risky drugs.
Yeah, that to me is where the culture thing comes in, because when you're talking about high school kids, and you know, I can't tell you all the stories I've read or even some that I've heard, but yeah, it's so prevalent and it's so accepted amongst kids. There's not even seems to be no peer pressure even to do anything about it, and that's the culture we have to get at.
Yes, sir.
Yeah, I'm in some of the task force groups that I'm hearing about, I don't hear about employers. Employers where I am, half of the people who apply for jobs can't pass the drug screening. And then,
We hear about that.
if they in fact go into treatment, what is the likelihood coming out of treatment in terms of the point she made?
Give an example.
Whether they would even consider, because they've been arrested, you know, for drug abuse, as to whether employers would hire them or not.
I'm going to stand up so I can see you. So, you know, there's a program that's sponsored in Martinsville by the Harvest Foundation. That was the Conversion Foundation for their hospital. I forget what they call the program, but basically, if you've been drug-free for 6 months, they take you in and try to re-enter you into the job market. I remember being in the room with them, and an employer had hired a number of people out of the program. He said, Doc, he said, I would rather hire someone that I know had a problem, that has addressed it, and is in the treatment and being monitored and going to meetings and so forth, than go on the street and hire randomly, because I don't know what I'm getting there. And the prevalence of substance issues, and when we had our meeting in Appalachian, you know, we heard about somebody, I can't remember, Kentucky or Tennessee, talking about the nice restaurant chain coming to town, and they were trying to hire a bunch of people. They had to postpone opening for 4 months because they couldn't find enough people who were substance-free to work. I know that I've heard stories of employers, particularly in Southwest, one employer trying to hire 500 people, and they could not, you know, over half of the people that came in were failing their drug tests. Now, I mean, how do you do that? How do you go in for a job when you need a job and fail your drug test if you really want? I mean, it's an addiction.
It is interesting, though, that here's just a point of fact, that individuals, after they go through the drug treatment program and they remain clean for 6 months, are much less likely to return to drug use than the general population, and most people are unaware of that. So, you know, again, people can change. There should be opportunities, and this is, I think, a societal question which we really have to deal with. We have to make it easier for folks to re-enter society after they've gone through these drug treatment programs and have remained clean They need to be able to get jobs. They need to be able to take care of their families. Otherwise, you're leaving them no alternative but to make bad choices again. So, we need to think about these reentry programs. They're actually very important.
You mentioned the program Operation Unite.
Yes, sir.
Is that a local program, and how is it
It's
instituted?
It is in a congressional district in Kentucky. It was funded by Appalachian Regional Commission. The congressman in Washington who oversees the committee for Appalachian Regional Commission, Hal Rogers, and the director told me our job is to make Congressman Rogers happy. But at any rate, they put some federal money into it, and it is basically a grassroots effort that they've done there. But they've turned this thing into, every year they have a national meeting. Our follow-up meeting, Wise Summit, is going to be in Atlanta at the end of March. But they had 1,400 folks from around the country. It's called Prescription RX. But basically what they've tried to do is address the whole gamut that we've talked about here, from drug courts to culture. But really it's more about getting the community engaged. And we're not going to tolerate this stuff. We're not going to tolerate these people giving the pills out. We're not going to tolerate the dealers. And the lady who runs it now is Lady Nancy Hale. And being from Kentucky, she says it's a two-syllable word, Hazel. But we can get you in touch if you're interested.
I was just wondering what localities can do independent of what the state provides.
Well, I've used the Winchester model. I would go and the judge, the juvenile court judge up there, I'll say her name in just a minute.
Judge Callis.
Callis, yeah.
Beth Callis, who I know very well.
Incredible.
Juvenile judge.
And the prosecutor is there.
Tim Coyne.
And Nick Restrepo from Valley Health are the three people that really, I think, are the linchpins to that I know of. There are others. And I would encourage, and I know they would go on the road and tell you what they've done, but I think that's really the model to follow right now in Virginia.
But being comprehensive, so involving all aspects of your community is really key. Not just law enforcement, but your, community activists, your parents, your schools, your local community health centers, or your comprehensive services board folks. So being as comprehensive as possible, taking a comprehensive approach, and then of course having this law enforcement being willing to prioritize treatment over jail sentences. I think if you use that basic framework, you'll be able to make progress. This is not going to happen. You're not going to turn this around overnight. This is going to take a concerted effort. You're going to need dollars to actually create those treatment slots, and you're going to have to stay at it. You just don't change a culture overnight, but you cannot walk away from this problem. It is not going to get any better. It is not going to resolve itself, and we have a lot at stake. This is our future.
We have a question over here.
Yes, I do. I live in the little county down in southwest Virginia that you have marked in the dark, Dickinson County.
Been there.
Yes, and we have a terrible problem, and to me, if the state of Virginia would spend some money on treatment, I know people that need treatment that they cannot afford to be sent off. Myself, I spent $9,500 to send a family member off. Most people cannot afford that, and we do need some money. We have consolidated our schools, and we have some idle schools that we would like to turn into a drug rehab place, that we are interested, but we don't have the facility, the money to do it. But we need state money to help with our problem.
There's, unfortunately, it's more than just
And
having.
my mother is a Hazel.
Oh, okay, Hazel. It's unfortunately, it's more than just the money, because if we had the money, we wouldn't necessarily have the people who are trained to do it.
That's our problem.
So, we're trying to deal with this, and I've just asked you to do a little sidebar. Who went to the budget meeting before this one? I saw you lurking in the back. We're talking about all of our issues, and let me tell you something about how we develop budget in the administration. Okay, the agencies come to us and they give us their wish list, and then the secretaries look at the wish list and say, well, if if we send this to the governor, it's gonna be public, and the governor's gonna can't say yes to all this, so then he's gonna get criticized for cutting it down. So what actually goes to the governor, and I'm now in 2 administrations, I've had experience with 2 governors, and this is something that you try to sort out what your priorities are. And I always tell the behavioral health folks, I say, or all of them, all ones who say, don't negotiate with yourselves. Come to me and bring the whole picture to me. Let's work through together. We sit down. But what had just dawned on me a few weeks ago is that we have not, by doing that, we are not giving the world an adequate view of how bad the problems are. We are not. And mea culpa, it's the way it works. So I won't tell a current story because that would be out of school, but in 2013, Jim Stewart was commissioner. And I will tell you that they brought us requests for over $250 million a year to begin to address some of what they perceive as the funding problems. Now, we put in during the McDonnell administration $160 million a year during the recession to bring it up. A lot of that was around the IDP populations. But my point to you folks is that this is far, far worse in our minds than I think people realize, because and I am guilty of hiding that number too. It wasn't a deliberate hide, because you do tend to look at your agency and say, yeah, but you want the new Tesla when a Chevy would work, and so there are things like that. But it breaks down sort of like this. We've got the DOJ problem with the ID and the DD community. We need the community services. We've got 200 people in state hospitals right now who shouldn't be there, and sooner or later DOJ is going to come get us on about that. And the reason you can't get your people in a state hospital isn't because we don't have enough hospital beds, it's because there's no place for them to go when they get out. We lost a person in a jail here not too long ago down in Tidewater, and the official thing was, well, not guilty by reason of insanity, should have been in a state hospital. Well, that doesn't mean they have to die in jail while they wait, but we aren't putting the resources into mental health at the jail level either right now. So you put these things together, you've got this whole issue of how we collectively build crisis services. The CSBs, in my mind, I think Emmett said in the last one that in some places they're well-funded, in some places they're not. I will tell you they're misfunded at best. And they're misfunded because there's no base level to allow the core function of the organization to work, which are the things you have to do, like TDOs, and we don't pay for that. What we say is you go out and you bill Medicaid for those where you're lucky enough to have a Medicaid thing, and the private sector won't even touch them because it's not enough. And we're going to make you take that money to fund all of your services. They did that to reduce the bills in the past. It doesn't work. And then we bitch at the system, and we make these decisions. Emmett made a comment earlier today about something that the secretary was doing. I said, but Senator, we were following the law. Sometimes our lawmakers are astounded to understand what the law says that they passed. Excuse me.
Well, in defense of the lawmakers, though, I just want to say, it is difficult because the way the General Assembly works,
too, in a way.
They are. The way the General Assembly works, and as you guys can understand, everything is sort of departmentalized. We all have our different committees, and so when an issue comes up that we all feel passionately about, we go to our individual committees and write the different laws and write the appropriation mark. But in effect, to solve the problem, you frequently need a very comprehensive approach where multiple departments or agencies are actually charged with solving the problem and getting enough resources to do it. I think partnerships are really the best way to go because I have found our local governments to be extraordinarily creative and willing to put some money on the table when they can get results. Now, will they be able to put enough money on the table? I think the state should be more than willing, and I will put in the appropriation mark, to fund model programs and to be able to identify best practices, because it helps not only the local government but for the state, because then we can take it around the state and show that this is a good value for its dollar. This, in fact, will get you the outcome that you need. So we have to be willing to try new things to fund models.
I would agree. If you heard me speak before, I've got basically 11 agencies, and we've got mental health here and physical health here, which means the brain and the body aren't connected. We've got the health department here, and we've got all the things that cause poor health over here in social services. And do you all think of your social service as part of your health department? Well, first of all, do you all think of your social service as your agencies?
We do now.
You do, you should. You should, because, and I call these our cylinders of excellence. We talk about silos, but they are our cylinders of excellence, because they didn't just get there accidentally. They're not static. They are aggressively pursuing the things they do in isolation of others. Now, I know in rural areas, I learned that early on, where there are not a lot of people, there's a tendency to work across because you need that. In other areas you don't, but I think we need to really think through a little bit how we structure, because we can squeeze a lot more efficacy out of our programs by working together and providing a little bit better and consistent oversight by understanding what they do than we currently do. There's no substitute for having more resources, but having these all over the place not working together well is not acceptable in today's world. We're working at the state level, at least with my people, to try to fix that as best we can.
I have two things. One, you brought up the TDO process, the detention process for the mentally ill. And one of the things that we see as a pre-screener are the addicts that come through. And we cannot detain them and telling their families, I'm sorry, we can't detain them. The ones that break our hearts are the pregnant women, who need treatment, and who that they're hurting their babies, and we cannot do anything but put them in we can't even put them in the mental hospital or the psych hospital to get the treatment that they need. And I don't know how we address that, but that's something that I think everybody in the CSB would agree, that those women there should be some way that we can legally commit them against their will.
I think it's worse than you say, because some of these women worry about losing their baby if they come in, because they know that Andy's going to come take their baby away. And in some areas of the state, like Washington County and so forth, the treatment for these women is actually in Tennessee. They've got a really good program across the border down there in trying to figure out when you have a neonatal abstinence syndrome, okay, so mom is Medicaid with Virginia, maybe not, because she hadn't had a baby yet. So the baby is, but then the question is, who pays for the baby? Who pays for the substance abuse treatment? And what happens to the child? And we've been through some ebbs and flows in our policies that make it harder for mom to keep her baby, even if she's in recovery.
And we can't place them there as a CSB. We
No,
can't
you
place them in
can't.
Tennessee, DC, or.
No, they've got to stay within your jurisdiction. I am very interested in some best practices, and I will do some research on that. If any of you seem to be an expert in the area, I would like to come up with a best practice in Virginia.
Well, we do have a good model in Fredericksburg, and he was asking how does the community come together. We have so what we found is homelessness is a huge problem in this population as well. And we have an agent, a social service agency, private. It's operated by 9 of the churches in the city of Fredericksburg called MICA. And what it did was it actually went to the hospital and said, you know how much it's costing you to constantly have kind of that revolving door. And so what they've really advocated and worked on a grant through Mary Washington Hospital and the Sunshine Lady Foundation to do the rapid rehousing. And so we have managed to do that in the Fredericksburg area through these partnerships. And what we're starting now, literally just started in June, is working with the jail for the same program. Is to identify these folks before they get into our jail, because we cannot treat them in our jail. We're a regional jail. We don't have the money to treat them with mental illness. Plus, if they get in there and mental illness, the comorbidity of mental illness and addiction, they come in there and Medicaid shuts off. If you go to jail, you no longer qualify for
But not under Medicaid expansion, by the way. Medicaid expansion wouldn't cover your prison population.
And so that's a real concern for us in the region, is how do we keep them out of our jail? So Mike has got a very good program. If you guys reach out to them,
Housing continues to plague us. One of the things we started under Governor McDonnell was a homelessness initiative with the people with severe and persistent mental illness. We've had pretty good success at that, and I'm going to brag just for a second. The governor is going to make an announcement on Wednesday, but it turns out we have housed over 1,400 homeless veterans in the past year. And he's going to make an announcement, there's going to be a national acknowledgement on Veterans Day, which is Wednesday. But, you know, we've been trying to do that, but of course, when I say we, that's not us. I mean, that's your folks and your continuum of care organizations in the
And
communities
the federal.
and that are working. But we did repurpose a lot of our own dollars too.
I just want to say there is a model, it happens to be in Arlington, the whole rapid rehousing issue. Yes, dollars are made available to ensure that folks don't become homeless, so they've got this big emergency fund. A study was done, and it was a federal study, that showed it actually costs a jurisdiction less to house somebody. It's about $45,000 a year. This is a national figure, to provide permanent supportive housing, and compared to $100,000 to keep that person remains on the street and services are provided to the person while they're on the street. So getting them into permanent supportive housing is actually a money saver. You know, of course, there's a lot of benefits just on a human level. But in Arlington, they created this homeless services center. So they have beds, so they can actually house somebody, I guess, for 3 to 5 weeks. It's a shelter. They have a day program, so folks who, it takes a while to get some people off the street, but they will come in during the day to wash their laundry or whatever. And so they're building up a relationship with these chronically homeless folks, so at some point they'll come into the shelter. Because once they are in the shelter, you need to have, we work with them and they have a plan. They have to, you know, go into job training, et cetera, et cetera. And they also have a program where they try to connect folks with their relatives. And they have found that that was a big reduction in the homeless problem, because everybody, I guess, somewhere at some point in their lives had a relative and they lost touch with them. And Arlington has made a concerted effort to find these relatives and then facilitate the connection. So the whole combination has been very successful. But it's a good safety net for sometimes for the portion of the population we're talking about who might be using drugs inappropriately.
We have a question back here.
Well, I had a comment and a suggestion for the legislation, just a little small.
Just a little one, those are the dangerous ones.
I'm happy to
This
take
one's,
any
Well,
suggestions.
I-
this will jump up and get you.
Yeah, comment or observation, and I'm not far from Dickinson County, I'm out southwest. And by the way, the comment is what may be a broad ignorance from a large part of the population, and I may be guilty of just being callous to this stuff, but out in the southwest, we tend to read a lot of news media from out of state. And I knew there were drug courts in West Virginia, but I had no idea that Judge Chip Hurley was running the drug court, or that he's been so successful. You know, as somebody who considers himself reasonably well versed in public affairs in the community, I just didn't know. But the suggestion, and this comes from personal experience, about 3 years ago, I inherited a stack of pills, and we'd gone through cancer treatment at, what's her name, down in Charlottesville, Carrie Center, Curry Center, and HIS in Bethesda. And so I inventoried those and had them stacked and all that. And I called my pharmacist, and no help.
Yeah.
And so I finished the inventory because I said, I want to have this in case something happens. And I stacked them up front, and I called him back. And I said, you know, I'm taking like maintenance prescriptions from you. You know, you're making money off them, you know, high blood pressure and, you know, that sort of thing. And I get these solicitations from the big companies connected to my health insurance wanting me to order this stuff online every 3 months. And I choose to stick with you because I consider you to give me customized service. So I'm going to bring these pills back down there. And I expect you to help me with these things. And I don't know what happened to them, but on the way, I got suggestions that I mix them with coffee grounds. And I thought about feeding them to the dog. I know better. I know better than to flush them down because I know a lot about sewage treatment, so I know I shouldn't be flushing it down the sewer. But it's like, you know, I know it's just a little piece of it, your incinerators in Alexandria, but brother, if these guys can make money off us, giving it to us, they ought to be prepared to take it back.
CVS,
That's what we,
CVS has been the leading sponsor of the drug return boxes, and your sheriff, or wherever you want to put it, can probably apply to CVS and get the containers to take back in. So that's one thing. And I think they are, if I understand correctly, they have recognized the need in their own population to address the drug take-back issues, drugs of all types. So I know that's one thing out there. You know, it's it's just, those are very, very real and tough problems right now. And what I'm hoping we'll find is that Tennessee will have a closer storage disposal place to you than we do in Virginia, and that might be an answer for an interstate agreement.
but you would like more take-back requirements.
Yeah, I just think if they're gonna make money distributing,
Yeah, I hear you.
they ought to be ready to step up. What was that term you used? No, it was the senator, like the governor on a man up and man that thing, you know, in the last session.
I get it.
But, you know, these pharmacists ought to be prepared to do what should be their responsibility.
One of the questions I think that won't happen in Virginia anytime soon, but is there some responsibility on the part of pharma who actually makes these pills and sells them to help us with the consequences of their programs?
Here.
Yes, sir, in the back.
I have a comment and a question. You made mention of monitoring these doctors that,
Yes, sir.
right, who does that? And
The Department of Health Professions maintains the prescription monitoring program.
is that a state agency?
It is part of the state agency, yes.
When they do that, when the doctor is really, you know, way up on the chart writing these prescriptions, do they have a talk with them, or?
They have not, historically, initially, that this was not supposed to be used for that, but we are working on the criteria by which that will happen now, because we want them to be talked to.
But because I live as far southwest as you can go, I live in Lee County, close to these folks. And I know our drug problem is really, really bad. And those numbers on that chart there are low, because a lot of people overdose, they had a heart attack, you know, that type of thing, you know.
The other thing that happens in border areas is you might overdose across the border, and we never know. I mean, I've had my colleagues in D.C. tell me that that on Friday night, you know, we're picking up people who are overdosing, and they're Virginians, and they go into our hospitals, and we've not connected the data yet. So that is one of the challenges that we're working with.
Yeah, well, you know, in Southwest Virginia, there where I live, you know, I can look and stand in my backyard, look south and see the Tennessee state line, look north and see the Kentucky state line.
You should clean up your neighborhood.
You give me the authority, I will.
So what United did, their program, they actually make the doctors responsible for it, and they're going after it in Kentucky, so that's part of their program, just so you know.
But what do you do when you know a high school student is?
So United, they addressed it,
You know, principals are kind of.
because they were losing too many young people, generations ago.
Well, over in Harlan, which is a little town about 20 miles where I
Just losing
live.
them left and right.
Listen, they were lined up down the street, going to this doctor's office. And they walk in.
Yeah,
No, you know, never look at them.
Treatment, there may be a much bigger issue going on in the
People from
family.
Virginia were going over
There
there.
may be some gang-related activity, you
Another
cannot
thing they do,
ignore it.
these
Now,
dealers
you have
will pick
one
out,
of the things that we're
find
trying to
somebody, an
reduce
older
is
person,
what's
you know,
called
elderly,
school visit
and they'll get them to go to the
pipeline,
doctor.
which is perhaps one of the
And then when they get
byproducts of
the
a lot of school
prescriptions,
resource
they're
officers.
together using
They give
But
them
if you
you
have
know,
one,
and they're living
that's
on a
someone
fixed
that you
income.
can use, 'cause
They'll
they
give
should
you five
know
percent,
what
yeah.
the choices are. If there's
It
another
happens.
problem,
No, it is happening.
if the school might have a counselor that you could ask, go to the CSB and ask to talk to someone at the CSB and say, what are my choices here? Generally, you might need to talk to the parents, so, but get some professional help, and I would think that the most immediate thing would be somebody from your CSB.
And one more question for you, Secretary. I noticed that these court board, these court,
Drug courts?
drug courts are very important. However, Halifax County, I believe we tried to apply for one and we was not approved for that grant, so what would be the next step?
I actually researched this when I was doing my talking points.
Okay.
This happened in February. The Halifax County Board of Supervisors was briefed on the drug court situation. You have to apply to the Supreme Court of Virginia. And it takes them a while to review the application, but I don't think, I can't say for sure based on the research I had access to, but you could certainly go back and reapply.
Okay.
And they're very clear about what is expected.
They have a limited number of dollars that they can use to support the courts is one of the issues. And Judge Lemon, the Chief Justice, is a big fan of these drug courts and would love to see more of them. But what I would do, I can't say her name right now, but the lady who runs the program is actually very good and helpful. And I think what I would do is I'd go up to Richmond. I'd call and say, I'd like to meet with you and I'd like you to walk me through what we need to do to get this. But that's what I would do.
And there's another thing, I need to say this, and this is thank you for your question, this is a good opportunity to say it. You don't have to create something that says drug court on it to be effective, to offer alternatives. You can actually provide training to folks who are on your judicial bench now and get them used to just using, community-based alternatives rather than the jail option. So you don't have to create a whole new system to get the same result. Now, some jurisdictions have, but it's a mindset. It's a way of dealing with situations as opposed to necessarily having a separate, dedicated court,
It's a
You
docket.
can do it either way. Yeah, it's a separate dedicated docket.
Yeah, there's a guy in Hawaii, a judge in Hawaii, and his version of the drug courts, he brings all of them in, it's on the docket in at 2 o'clock on Friday, and they pee into the cup. And if there's drugs in it, they get to spend the weekend in jail, and if not, they go home, and it turns out to be a pretty good deterrent for those people.
It's called Good Friday.
But it's pretty.
It's called Good Friday.
Who is it in the local government that would do the legwork of the application? Like if Dickinson County, I don't know if you have a drug court.
We did have
Court,
drug
your
court.
judge,
Okay.
your chief judge.
But we pay
So
for
does
it.
he have somebody working for him?
Yes, your clerk of the court.
The clerk of the court
Yes,
is that's where the buck
that's-
stops.
The clerk
in
of
the
the court
local
would fill out the
jurisdiction.
application and do the paperwork.
It's broader, you need, if it's gonna work, you need the prosecutors involved, and so they've got to be in the buy-in, and you've got to have the sheriff involved. And I know in your area, Tazewell's in, but I think the guy in Russell, he's okay with the drug court, but he doesn't want to do medically assisted treatment, from what I hear.
Well,
I know down in Abingdon, they're actually looking at putting an inpatient thing on.
one of the things I noticed in our local election, just what was that last week?
Yes.
We had competition from Commonwealth Attorney's Office. And for the first time in my memory, issues like this were part of the campaign
Well,
rhetoric.
that's a good thing. I think that's a good thing.
Which is a good thing,
These are
but
important issues.
had the Commonwealth Attorney not had some competition, I'm not sure if that would have taken place in that arena of that electoral process.
Well, in Arlington, that's unfortunate, because these are very important situations, and they really affect our whole community. With the process Arlington used to get a drug court, we had our Commonwealth attorney prior to our current one after they opposed. So we had our chief judge set up a task force that included the prosecutors and the legal community, and of course, the defense attorneys. They decided that, something called the drug court was a good thing, and then the clerk of the court did the paperwork to get it moving.
Thank you all. I think we have one more
Just one more
question here. We're
question.
out of time, but we'll take it.
I think if you all have a good hospital in your community, they are the best barometer of the problem that you have, along with the police department. But the little babies that come in that have to stay there 12 days and cost $10,000, $12,000, I've forgotten how much it is compared to a regular normal birth. And who they treat in the emergency rooms. If you can start working with, get your hospital, the local hospital in with the police and so on, you can start doing things in your community, because that's what's happened in Winchester. They've been great. And they put their money where their mouth is too.
Yeah.
Thank you
You
very
were a
much.
very attentive group for a session that started at 3:30. I'm really impressed.
I was going to
So
say
thank
the
you.
same thing. Thank you very much, and let's give a hand to Secretary Hazel. Thank you.
I should have sat over in this wing. Just fine. So what do you think? Is there any light at the end of the tunnel or something?
Did